Great. So today we are talking about culture, and in addition to the session content, this session format may feel culturally different from other sessions here at the summit. This will be a conversational interview style between the two speakers. And so audience members throughout the session, when you have questions, please add them to the Q&A box to the right of the chat. And if you see a question that someone else has asked that you like too, you can vote for it, and I will bring our speaker's attention to it as we go. During the session, my video and audio will be off and I will drop out of sight, but I will pop my video and audio back on to indicate that there is a question that aligns with the topic our speakers are addressing. So let's begin with some brief intros. Next slide. There's all three of us, and we'll do some more brief introductions. So next slide. So my pronouns are they, them. I'm Dr. Michelle Carnes. I previously worked at SAMHSA in Indigenous Suicide Prevention, and I'm now at HRSA working in telehealth. And it's my pleasure to briefly introduce, next slide, Dr. Carey. She is a psychiatric nurse, addiction specialist, and counselor. Next slide. And Dr. Michelle Evans. She is a therapist with Nickerson and Associates, and she specializes in working with Latinx populations. Next slide, please. So Doctors Carey and Evans have a lot of content to share with you today, and we also have a one-pager of resources for summit attendees, and thus it is my pleasure to pass the ball to our presenters to get us into this exciting session. You may begin.
Excellent. Hi, everyone, and welcome. And Dr. Evans, thank you for this time to present together. So Dr. Evans, can you tell me a little bit about your clinical background, about your practice, particularly with a focus on telebehavioral health?
Certainly. So as I think about how I arrived here at, even here in this conference today, it has been a long development. I know that recently, within the last 5-10 years, I've been teaching at a university, and I remember that was my first introduction to telehealth. I've previously been a therapist in multiple different agencies, but it was really in teaching where I started to get access to, what is this new thing going to be? How are we going to use online, both in teaching, but then of course in the clinical world. And I think the first thing that, as a therapist, when I was introduced to it, I think like 10 years ago, the first thing I thought was, no way, this isn't going to work. Come on, therapy, teaching, it's all about being present, being there, what you get. I remember even saying, hey, if you can't see somebody, if you can't see the whole person, how are you going to do this? Which really clashed with my personal style of therapy, very engaging, very gestalt in some ways. So I've experienced being a therapist and just thinking about those things. Currently, I'm also the hospital administrator of Elgin Mental Health Center, where I'm responsible for a lot of larger decisions about deciding where the facility is going to go regarding telehealth, and so therefore, both in my practice as a clinician, my experience as a faculty member, and now as an administrator, I know that watching telehealth come toward us and knowing that this is the future and is going to really allow us access has really impacted, just how I've started to think about this. And I'm really, Dr. Carey, I'm really excited to hear about you because I know you've also had a lot of experience in this area. And so I'm really excited about being able to learn from you and the audience as well today, as we talk about this and just how we really integrate a lot of these cultural adaptations to our current practice. And so how about you? Can you tell me a little bit about your background?
Sure. So I am originally from Michigan, started there as doing clinical psychology. Once I earned my master's degree, I went on in clinical practice with youth primarily, as my focus when I started my doctoral studies was for children in school counseling, and as well as children and adolescents in the clinical setting. So I worked with them like you face to face during those times. And I've always been consider myself a clinical techie and really wanting to connect in different ways. And so as time went on, even in collecting data for my dissertation, I started to use the internet. and really leveraging social groups for the most part. Back then, AOL was separate from the World Web. Dating myself a little bit there, but so I just really became interested in it. And as I developed new areas, when I relocated to North Carolina, where I currently practice, I just really wanted to increase access and to integrate technology into my practice. And so when I started teaching, like you were describing with your experience as an online instructor, it just was a natural integration of presenting this information and using technology to reach larger audiences, as well as at the time what I thought was increasing access. But I did find that there were some challenges along the way, and perhaps we can get into that in a little bit. For clinical certification, that was in 2008. So I was a really early adapter. Certified tele-mental health provider certification that can be earned. And so I was grandfathered into that too. But there's continuing education and a lot of considerations when we think about telebehavioral health services. So if you could advance to the next slide.
And maybe I want to add, Dr. Carey, just for the audience, one thing that you and I do have in common as well is we've spent a lot of time working with underserved populations. And I know we're going to be talking a lot more about that later on in our presentation, because that's really, kind of an area close to both of our hearts. Yeah, so I'm looking forward to that.
Absolutely. When you were first offering your services online, what were some of your feelings and some of the feelings that your clients had when you presented the idea of not coming into the office and still engaging in counseling services?
Yeah. Well, so the populations I work with are primarily individuals who are underserved. Often, I work with, in my current work as a therapist, I work with adolescents and adults. Many of them are underserved, they don't have a lot of technology. And so over the years, I've been asked, here and there for a little telehealth, just to be able to mitigate individuals who don't have cars. People that can't arrive to their sessions, just trying to overcome some of those difficulties. And I was always very hesitant because I think my own bias was, especially because I work with a very heavily mandated population, the majority of individuals that work with me, I work a lot in drug treatment for individuals who have sexually offended or have sexual behavior issues. We're with parole and probation. And so a lot of the individuals coming to me, my bias was they're just trying to get out of something. They're not trying hard enough. And it really was an internal bias, because even though I've worked with underserved populations, I recognize transportation is a privilege. I live in an area out close to Chicago where, but we're in the suburbs where it's a necessity. And so, but as I looked at these, I found myself, just that immediate reaction of, yeah, you know what, you just don't want to come to the office. You don't want to talk to me. You don't want to do this. This is an easy way, an easy out just by doing it via phone. Because some of the individuals I work with don't even have, they don't have Zoom technology or web, video chat technology. And so initially we started there. COVID-19, of course, and I'm sure there's many people, also listening today, had the effect that, okay, we can't put this off anymore. And so I very reluctantly started moving much, to make, well, it's one point, all of my clients, telebehavioral health. And I found that all of a sudden, I have to say, in the last year, I don't think anyone's canceled due to transportation issues. And so, and so all of a sudden I'm looking, but, my question has always been, regarding my feelings was okay, is this the same level of service? How do I provide this service and make sure that I'm still, offering the same level, still achieving the same goals, also engaging them and communicating, because unfortunately, as I mentioned, I'm more of a gestaltist therapist. I can't see them. And so therefore, I remember my first telehealth sessions a couple of years ago, And there was a lot of silence and a lot of wondering, on both, I assume both ends, of what's going on, what are they doing, because I wasn't used to kind of talking about even my own feelings as a clinician, as we were going through the session. And so maybe I'll pause here and, just what about your feelings? I know I want to talk about clients, but what was your experience?
So I was, of course, very gung-ho, like, yeah, let's do this thing. With technology, I thought that my clients would love it as well, not necessarily having to travel to the office and all of that. But I did find a lot of pushback from them. And I was shocked because, of course, as a person that's in the academy, you're looking at the research that says, hey, this can be just as effective. These are the positives about it. And so I really didn't understand it. I really had to take a step back and put my own feelings aside and really listen to what the objections were from my clients. And their concerns were kind of opposite, just like you described your concerns about your clients. The clients had the concerns about me. Well, how will you know this about me? Well, how will you know that about me? Well, you won't be able to see me, fully if we're using like telephone technology, for example, instead of a chat like we're doing today. And so it really caused me to step back and realize I needed to do a lot of education with my clients to prepare them for the change. And once I began to do that, the reception was far greater. And those clients that were the most resistant to trying it online, I just offered to them, hey, let's try it once. If it doesn't work, then we'll go from there. And for even my most resistant clients, the ones that didn't want to come to the office at all, I probably couldn't pay them to come into the office now because it's so convenient. They see me using their cell phone device, for example, in their car on a lunch break. And it's part of their day, and they eat their lunch and we do our session. It also allows me to see them in their own environments. And so I can hear interruptions and I can hear noises in the background and really get a more of a sense of what my client's life is like that they try to describe to me in the office. I think I have a deeper appreciation for what it's like for them in the settings where they are and in their own native settings. And I also find that I get a lot more from them, not content, but I get more of what we're looking for in the counseling, the goals that we're trying to get to, that sharing of feeling, getting to meaning about the situations regarding the content that they present to us. And I find that the sessions are much deeper and I'm able to relate to my clients on a much deeper level. And so I really appreciate that.
Yeah. Well, and I appreciate that because I know and I'm thinking about as we move to this next slide, just discussing some of those assumptions of telebehavioral health services that.
And in thinking about that too, Dr. Evans, with the assumptions, we didn't have much room to assume once, as you mentioned, COVID-19 hit. Kind of everyone was thrust into having to use these technologies to see their clients, and it was novel for many practitioners to do that. So for anything that COVID has been, we've heard a lot of things of how horrific it has been, and I completely empathize with any situations where COVID has touched people's lives. All of the people that we've lost secondary to this virus, my heart goes out to them. But one thing that I have sincerely appreciated, just not about COVID, but just about the situation that COVID had thrust us into, was broadened thinking about how and when and different modes in which we can deliver what people need, especially with the uptick in the mental health concerns secondary to COVID. I was very appreciative that I was already in the online space and able to assist and support people who were impacted by this pandemic.
Yeah, I definitely agree. One of the other modalities that I offer telebehavioral health is in groups. And I know that's been really just beneficial, as I have a very specialized service. Often my clients drive an hour, sometimes up to 2 hours to get to my sessions. I've had some of my clients go away to college, especially recently, and they've been allowed to, especially as we look at the group process as a place where they can connect and maintain support. As I see them, either traveling or, up here in Chicago, we have some winters that can prevent you from attending group. I've been able to see that it's allowed them to develop better connections from where they are. And so
can you also share, Doctor, I'm sorry to interrupt, but you talked about groups and using online technologies. Perhaps our participants here can benefit from knowing what platforms you use that are regulatory compliant to have the groups and hold the groups.
Yeah. So we've been using Zoom, which does have the BAA, to allow us to provide therapies through that.
And the BAA would be the business.
Yeah, the business. And I didn't want you to ask me that because I know it's the business agreement something.
I think so the BAA is something that's required in order for the platform that you're using to be compliant with what our regulations are for privacy. And so you need to have that business agreement on file in order to be HIPAA and vis-a-vis high-tech compliant, which are federal regulations for our profession.
Right, exactly. And so I was really excited when Zoom, because I know very initially, there were some questions about that, but Zoom does have that. And so we actually use, because I have many individuals, like I said, I have individuals on parole and probation who can't use or actually prohibited from using the internet. And so some of them are calling in via phone, whereas I have others that are participating via video. And then I also have other people that are sitting in the room. There are certain individuals due to sometimes disabilities or due to hearing that the telephone, it wasn't working for them very well. And so they benefited much more for being in person. And this has worked really well because each individual is able to kind of attend the group in a way that works with all of the different factors that are impacting their lives. And so right now I do have a group where, there's one or two people on the phone, one or two people via video, and then several others. I think I have about 5 that are actually sitting in the room. And we have to be mindful, of just making sure we're including the people we can't see. I know physically running that hybrid group at times I make Post-its and put it on chairs. So we have that visual representation of, hey, don't forget, John is here in the computer. He's not with us right now. But after a period of time, people have really developed, just getting used to that. And when you have a member who's sick, has the sniffle, they can call in that day. They don't need to miss group. Whereas in the past, I had individuals missing due to all sorts of just traffic or sickness or things. And so it's allowed a much better way for them to stay consistent. And so just like you were talking, we see much better cohesion and connection because people are connecting in a way that's most comfortable for them, and I found the group members are very accepting to that, of just, okay, this is just, we had a member with a back issue who was consistently standing up and down throughout group in person, where it's been so much better having him in a place where he's comfortable, where he's not giving so much movement, which is distracting to the group. So there's just been so many benefits, I would definitely agree with you on that.
So, and speaking about population barriers in relationship to populations, I see usually they are lower income families or families without a lot of resources. And often they do not have smartphones or access to technologies. It's been even more detrimental impact on them since COVID, when they couldn't go and use technologies, people were in quarantine and what have you. And so in order to address certain populations, there are certain things that you need to do or that you can do, which we'll get into soon. But I just wanted to highlight that not everyone has a cell phone, not everyone has access to technology. And you talked about a little bit earlier in our chat, Dr. Evans, about that. And so I wanted to remind our participants that you can pop questions into the chat or the Q&A at any time. We'd love to answer any questions that you have or discuss things with you also. And in the meantime, while we wait for those posts, Dr. Evans, can you talk a little bit about populations you specialize in and what barriers they might face?
Certainly. As a Spanish-speaking therapist, I work with a lot of individuals in the Latinx population. Like I mentioned, I'm outside of Chicago in a suburb that is highly Latinx. It's, in fact, I think we're running about over 80% of the population. And so, but I'm also surrounded by some areas that are, that are not, so I have quite a mix of clients sometimes. And what I found is that, just like you mentioned, just access to technology. That was one of the first, areas of privilege that I found for myself of going, okay, I just assumed everyone had a smartphone or, knew how to access the internet. I was talking to someone the other day who well, you could just Google this and find out where it is. And he shows me his smartphone. He's like, I only have it so my daughter, can hook up to the internet. And that is it. He's like, he didn't even have like the Safari or anything on the phone to even access the internet. He just had it as a hotspot so his daughter could participate in school. But we also see some cultural barriers, as we think about, we are currently in a conference that is, completely virtual. And I found that when we're working with individuals, either generational or even we're thinking about seeking mental health care and the stigma that comes with mental health care and having to approach it with somebody who is on a screen, we really have to look at, in the population I work with, that personalismo, that personal relationship that you develop is so important. And so initially, as I was trying to identify how to best work with my population, I myself had the barrier of what am I going to, if I can't see them and, just, show them I care, how am I going to do that? But in the other way, and I know we're going to talk about, things that have helped, I found that I'm more accessible because there no longer is I'm sorry, I'm not in front of your sessions at 3 p.m., and I'm not interacting with you, because this naturally opens up the world of texting or the world of, having a much more integrated into their life, calling them as, an aunt or a sister or a mother would, as opposed to this formal doctor that's sitting in the office and you have to sit in the waiting room before you see them. And so it's totally changed the context of how we meet, which I found was really, really amenable to the population I'm working with. It wasn't just a sterile office anymore. I'm coming to them.
Exactly.
What are your thoughts?
I found the same thing with doing in-home therapy. It's like you're meeting them on their turf. They just seem to be far more comfortable rather than being in the office. And we have a question, Dr. Evans. Earlier, you mentioned putting the sticky notes on the chairs when you have some people in person and some people virtual. And so the question was, what technologies are you using so that the in-person people can also see and hear the virtual clients?
Yeah. So I actually purchased a speaker, an external speaker, because I use my laptop just like this. And so everybody can see, but I have an external speaker so that individuals, because it's a rather large room, COVID, and so that's improved the quality of sound that everyone's getting. And so that was the primary thing of just making sure my laptop was quality and then having that external speaker. The other thing that I have to do as a therapist, which sometimes is a little difficult, is I have to actively monitor to make sure that people are muting at the right time. Often we get individuals with poor, they don't use this technology a lot. And then if they're not muting, other people can't hear,
Right.
And so that's been a little bit of a management thing, but it's just being mindful of that. And really, I've been able to do this primarily using Zoom, and I haven't, and so I've been really, really thankful that it hasn't been a huge cost on the agency or myself.
And what I've done for hybrid groups is the same. It's kind of like you have this technology that you need that's actually physical equipment. So definitely plugging in a speaker into the laptop, which then serves as the speaker for your computer for the people that have called in, but also making sure that the acoustics in the room or the group circle is close enough so that the person on the phone can also hear the people in person, because sometimes that happens. So to address that, I also have an external microphone that I use. So, and that really helps for the persons who are not present and on the phone to hear everyone and not just myself because I'm closest, you know, to the computer or laptop that I'm using. So there's a combination. We have the virtual, which people can hear and see readily, but also we have actual physical technologies that are used, such like we will said, an external speaker and microphone can come in handy. Really low cost. You can find them even at secondhand stores or online.
Yeah, I think I got mine for 30 bucks on Amazon.
Coming. I was just reminding our participants to please keep their questions coming.
Yeah.
So how do you address the barriers for those that you were talking about that may not have that access? What resources or ideas or suggestions do you present to your clients?
Mm-hmm. Well, I know, you know, we have had, I think the biggest barrier that we've had is often knowing how to use their own technology. And sometimes, and it's felt like a little, sometimes it feels like a little shift. You know, as a clinician, I'm there for therapy. However, sometimes we do have to pause and assess, okay, do you know how to use this, and have practice sessions and things like that. You know, I found that to be helpful, you know, but also just preparing individuals for what's expected. And I think that's often I have, you know, I've had individuals who are living in situations where it is very hard to achieve privacy, you know, and I think that's, you know, I've done sessions where I'm, you know, watching the individual who's sitting in the laundry room of their apartment building. And therefore there's a discussion and there has to be a real, okay, you know what, let me know if, you know, I should stop talking, or, you know, just give me a signal of, you know, wait 1 minute if somebody's coming in the laundry room. You know, I have a kid who participates in his group, and I know he's sitting in the hallway of his apartment building because that's the only place he can achieve privacy, you know, and it really is difficult. He's one of my only kids. I have an adolescent group and all of them have video except for one, you know, and so he's sitting in the hallway. And so some of that's helping, first of all, him to know what he can do and advocate for himself of, hey, I need that repeated, or, hey, I can't see this, you know, to be able to speak up, but also orient the group of, hey, remember, you know, John can't see this. So, you know, please, you know, describe what you're doing a little bit more, you know. Are there things you've noticed?
So yes, what I do is I will also ask, you know, what do you have access to, and try and troubleshoot with them from where they are. So if they have a telephone, for example, I'm happy to talk with them over the telephone. But then there are considerations with that as well, too, right? Like pregnant pauses or tone of voice, pace and cadence with how they're speaking to you. So it's really important to be attuned to those things because you can't see them. But for those that may qualify or be interested, I am very well aware of many resources that are available, such as governmental phones that are free of charge to people who qualify. Some of those qualifications may be they're Medicaid recipients or at the poverty level. So you would have to know about community resources such as that. So I make it a point to know about local resources as well as federal resources for my clients to be able to gain access to for concrete needs. And I would encourage everyone here to be very familiar with services through the United Way, using 211, and even searching your app store inside the Android and inside of the App Store. If you have an iPhone, you can just search different things like counseling services in your state. So I may search every now and again for like counseling service, North Carolina, and find different resources, or go to the United Ways app and see, you can type in whatever your client might need, clothing, furniture, for example, and then they will give you a list of resources based on the zip code you type in. So in the search bar, there's the item that you're looking for, and then you can give the location, and you can find a lot of resources that way. So for the populations that I see, a lot of them, again, if you haven't eaten, there's no way you can really pay attention and be fully present in the counseling session. So then having that basic, you know, bottom level of the hierarchy, Maslow's hierarchy of needs, you need to eat. So I'll refer them to food kitchens, for example, because even though that may not be why they're seeing me and why they're in counseling, it's a barrier for me working with them that they're starving. And case in point, I had a client once that just wanted to come like immediately after school. And so the client just made their own like standing appointment, on Wednesdays after school. And so at one point there was an exacerbation of symptoms and behavioral outbursts, and the child's like, well, I need to see you more often. But it turned out that because I had snacks in my office was why this child wanted to come, and the last meal they would have had would have been in school, and they didn't necessarily have, what we would consider full dinners, in the evening time. So having that snack, immediately after school was a huge thing for the client. But in listening to my clients and talking with them and understanding what they needed, then I was able to reach out and help. And when we're talking about online telebehavioral health, it's really important then to listen for cues from your clients about the things that they may not have, but things that are impacting their ability to show up fully and present with our every session. And so I would just encourage everyone here that when you're using telebehavioral health to deliver services to your clients, that you listen for cues like that. And you'll know your clients after a while. Rapport will be established, and perhaps they'll just come out right and say what it is that they need. And you'll be on standby, ready to help or refer them to a place where they can get that help. So I am always about using any of the technologies that I have, particularly app stores, Google Play Store. There's a wealth of help and information about help in them. You just have to get creative and search them to find information, and you can readily then share it with a link, because everything has a little triangle with the 2 dots on it, or the fish mouth with the 2 dots, not quite a triangle, where you can share information with your clients. So next slide, please. And Dr. Carnes, do we have any audience questions?
I know personally, I'd love to hear, because I see there's some audience members, and I'd love to see their thoughts as well, or even something they have to offer. In other words, things they've done.
So we'll give them a little bit to ask us any questions they might have so far. And it doesn't have to be on anything that we've talked about. If you have any questions about telebehavioral health, relationships with your clients, or your own feelings about delivery, platforms, etc., we're happy to share that with you.
And I guess while we're waiting, maybe I'll offer this question to you, Dr. Carey. And so can you tell me more about your cultural influence of your culture and how it impacted how you offer telebehavioral health?
Sure. So when I think of culture, it's not just about, being an African-American female. It's definitely much more broad. So my experiences of growing up in the inner city, I definitely have had experiences with scarcity and food insecurity, and really being marginalized in other ways, and not having access necessarily to things that others may have had ready access to. And so on that note, I can really empathize with the clients and the barriers that they may have in engaging fully in therapy with me. And maybe that's why I tend to know about what resources are out there and what's available to try to make things better for my clients, not only in a concrete sense, not only in a therapy and mental health wellness or holistic wellness sense, but in a concrete sense as well. I think they go hand in hand in order to address the whole person. And so for me also, the stigma with accessing mental health services, very palatable, especially for specific faiths that may believe that you need to cast your cares on the higher power and not rely on counseling services per se, so that's where your relief and help comes from. And that was my upbringing, that if you have to see a therapist or counselor, then something must be quite wrong. And that person is not able to help you anyway. And so basically it's a waste of time. So with those experiences, I've become very much a champion of removing stigma from gaining access to mental health services, and very much a promoter of, it doesn't have to be a problem for you to see a counselor. You know, counseling isn't always problem oriented. It may be that you're doing great and you want to do more great. It may be that you have a situation that you want to process through, that you'd like someone objective and removed from the situation to help facilitate you towards wellness. And so those are some of the things that I look at. Also, in thinking about lower income and marginalized populations, I also think about people with more affluence as well, that you have all of this and you have all of that. What is wrong? Why are you depressed? You shouldn't be depressed. And like that judging, especially using the word should and shouldn't to put a label on someone and what they are feeling, which may also deter them from seeking services as well. So when we think about stigma, it's general, right? It's stigma about a person, not necessarily always about a particular group. And so those are the messages that I try to reiterate over and over again, that counseling doesn't necessarily have to be problem oriented, and how helpful it can be just to address holistic wellness and not necessarily always a.
Thank you. I see we do have an audience question.
So the question is asking for us to talk about using telehealth and mental health texts in the process of getting people in contact with services in the community. So taking therapy to them through connecting them to in-home agencies on device. I think they're asking about how we can connect them through maybe one of the apps in the device. If the person who typed that question can just clarify, is that what you're asking? How we can connect them, like as clinicians, to certain apps that will tell them about in-home agencies on devices? I just want to make sure that I'm answering the question fully. And while we wait for that clarification, I can speak to in-home services and community services. I did serve as a clinician in one of our rural areas about connecting with community services that are in home. So for example, if I have a client that I think can benefit from in-home therapy, then I'm definitely going to refer them. Many of the in-home agencies also accept Medicaid. And so many of them would be on the Medicaid websites themselves, or they may even show up in that United Way 211 app. So that's a way that you can connect people, and also a way they can look for services in their home. Mm-hmm. And the question looks like it's been clarified. Have you utilized MHT to connect clients to therapy services while they're in their homes? And for me, I have referred my own clients to connect them to in-home services. I also will say that many of the clients that I saw that maybe were of lower income weren't aware of the services that they could connect to. And then the question is further clarified with taking a device to the client's home to help them connect and not miss sessions. So I myself am a solo provider, so I don't have access to the phones. But what I was speaking about earlier with the government phones that are available, it's an application that can be completed online, and the government will send them the phone. And because of how technology has evolved, it typically is a smartphone, and they will have access to unlimited texts and access, up to a certain amount of data for the internet when they're not connected to Wi-Fi. unlimited when they are connected to Wi-Fi, but it's a very limited talk minutes. So I often will tell them that, like, this phone is for us to be able to connect together. They maybe go to a McDonald's parking lot or something in their car if they have one, or walk to one or what have you. And they're able to access the Wi-Fi that way from some open source of Wi-Fi if they don't have it at home. Many clients now, many more have access to Wi-Fi hotspots at home because the schools have given them out secondary to the COVID pandemic. So my part is facilitating them getting the device, and I will look for that link and put it in the chat or make it available after this session with our resources, so our audience participants can access that for clients that it may benefit and they may qualify for.
Yeah.
Dr. Evans, do you have any resources or anything you can add to that about devices or access?
I agree, and I agree with the the phones that are accessible for individuals who are low income. The one thing that has been the best, thank goodness, are students who have received laptops or some sort of technology from their schools. I've worked with multiple schools of getting the authorization to be able to use that computer or laptop for our Zoom calls for their therapy. And the schools have been very, very supportive. We make sure we get authorization to make sure, everything is good. But that has been for any of my clients who either have children in the home or the children themselves. That has been what we've been using. And from what I hear, most of the schools in my area are continuing that. It's proven to be very, very valuable, as that's the children are doing many things on that, but I definitely agree that's a good one. The other thing we've done, and this is in a hospital setting, in the hospital that we do have, because we have, I'm a very, very large hospital, and so we have done a lot of bringing technology in to be able to interact using iPhones, using tablets across units. This has been especially helpful as we're talking about hospital social workers being able to connect with people, but not being there and present. However, what it's actually done is it's allowed us to be much more flexible in scheduling. Previously I had to, if I had a social worker who had to go and see specific people, they just, hey, I'm here, I'm present, you need to do it when I'm here. Now, because of technology, schedules are much more flexible. They don't need to go all the way up, and they can kind of fit our technological visits in much more flexible when other family members might be there, or that we can bring in family members from outside. But obviously, this is technology that's owned by the hospital. That patients are using while they're patients there. And so that's been extremely helpful in minimizing, contact due to COVID, but also including family members. And that's another benefit that I think we're seeing, as I think about how we're moving forward in mental health. So many of our underserved populations, our under-resourced populations, have cultural values of family. And until now, as we were talking about mental health stigma, it's been very much of, okay, if you have a mental health problem, if you can't deal with it within your family, which is the number one place, or with a higher power, well, then I guess you have to go to the doctor who's outside, in the stuffy office. And now we're able to incorporate family. I had an impromptu family visit. Within 5 minutes, I assessed that, we need to bring parents in here. And okay, the kid ran and got them. They were just in the other room, as opposed to them driving around or went to the McDonald's during the session or whatever. And I think that, personally, that rings true for me in terms of how I deal with my own mental health. It's including family, it's including people, as a thing that's a regular thing that I do, as opposed to, just something that, you have to go outside for. So that's been very, very appreciative. I've been appreciated.
You talked about the schools and how they had given the Google Chromebooks, at least in the county where I live and the students are there, they all received Google Chromebooks. And that too has made things more readily accessible for clients to be able to gain access to services, because they are laptops, they do connect to the internet. And so in speaking about silver lining, if any, we can gain from the pandemic would be the mass distribution of those Wi-Fi hotspots, as well as the laptop computers.
Mhm. Yeah.
And since that question was asked about devices, I believe, or our wonderful moderator put it in the general chat for people to be able to access the federal Lifeline, and that's what it's called, Lifeline cell phone. And one of the other things that I would want to share with the participants is Google is your friend. And any question you have, it doesn't have to be fancy. You just ask it as if you would ask anything. You know, how do I get a cell phone for free? For example, you could type that in and Google will have many answers for you. So always check the search engine, Google, just be as plain as you can with your requests, and things will come back. I'm always available as a resource as well. My contact information is on the slides, and I'm sure Dr. Evans will be willing as well to help connect to resources as needed. And I think as professionals, that's one of the things that we don't do enough of, is rely on others and just say, hey, I'm seeing this client. Maybe this particular thing is unique about the client. I know that you also work with this population, or maybe you have some ideas about how I can be of assistance to this person. And we're helpers, right? So we can help each other and not just be of help to clients who seek our services.
Yeah, definitely. I definitely agree. All right. Well, I think I could give you a little bit. I don't know that I talked much about my own clinician culture here on this topic. One of the things that I think about, as we think about clinician culture, is some of our expectations of the healing process. And as I think about how I see illness, I mean, people come to therapy usually with an identified problem, or something they'd like to improve. And obviously, we like to think of mental health as just another health, but that's not what brings people to therapy. Usually people come to therapy when, this is the last thing that, this is my last opportunity, my last option. And so I believe that was also something when I started approaching telebehavioral health. I, first of all, was kind of thinking of my own way of how am I going to work with people within this new context, within this new environment, because often my world was so interactive, and culturally I like to see the entire person. I'm very hands-on, seeing people interacting. It's an entire body thing, and I note their entire body during our sessions. And so I know I've had to change some of my own dependence on the context and watching the nonverbals to be able to become more verbal and talk much more about I'm feeling right now, whereas previously I would use much more of my body in communicating with my clients. And so that's one little element of culture that I'll give to the audience as well, is just to think of the kind of assumption of how do you take in that communication, and what's your cultural bent on how much we communicate with language versus versus the nonverbals. I think that was one of the biggest things that I had to get over when using telebehavioral health.
Yeah, I agree with you. I think that it made me far more attuned to tone of voice, cadence, pace, size, where I may have taken all of that for granted in the clinical setting when we were face to face. I was wanting to leave our participants with a little bit of information about the nuts and bolts of telebehavioral health and how it may differ from when you're face to face. And Dr. Evans, please feel free to chime in on any of these topics for the nuts and bolts part of telebehavioral health. I want to just highlight that everyone is not appropriate to use telebehavioral health technologies. Someone who may be engaging in self-harm, for example, or have a severe and persistent mental illness that may prevent them from participating, then that person needs a referral to somewhere that can definitely be more available than myself as a individual solo practitioner. to more of a holistic team approach, like the mental health treatment community team that one of our participants had asked about earlier. So you really need to do a good job of screening the clients. What is bringing them to counseling? How were they hoping that counseling would help them? Have they been in counseling before? These are all questions that you want to ask just in the screening process if you're considering giving telebehavioral health services to a client. One, because the liability can be very high if you have a very highly suicidal client. And then two, you want to make sure that the client's appropriate and can participate fully in the sessions. Gaining consent, it's a telebehavioral health model, right? So I had to get used to sending out my consent forms and information about the practice electronically, because that's how we're doing it. So making sure that I have a confidential email that's secure, that can send these documents, and that they can be filled out and sent back. And I even got even more fancy lately with having them fill it in PDF style, where then it comes back to me and uploads right to their chart, which is a really cool feature. And Dr. Evans, can you speak to how you do your intakes and assessments for telebehavioral health?
So I know with intakes and assessments, I actually don't think it changes much when we're looking at telebehavioral health. I use the DSM-5's, the cultural competence model, as for most of my assessment. I use a lot of those questions, which are very, very contextual as we go forward. And a lot of them are very problem solving. I do try to include family members. And so often telebehavioral health is can be very flexible with that, of having someone either call into our session for that point. But a lot of it is also talking to the individual about their situation, their environment, what would impact them, where are they going to have these sessions, and I think some of this is the orientation to what telebehavioral health is, and making sure that they have a comfortable place, and then sometimes reinforcing that. I've had conversations with individuals where they were clear that, hey, you should be able to do this in a private environment. But then, we actually have the environment and the TV's on and people are walking in the background. Sometimes it's that clarification of, okay, how are you feeling? Is this an environment where you can talk about the things that you want to talk about here? And sometimes it's giving it back to them of what are your goals here for treatment, and can you do it where you're sitting, where you're choosing to sit, because often they don't see, they're like, yeah, the TV's on. Oh, that's a problem. It's like, yeah,
exactly. I'm very paying attention to you. And so, and also thinking back to the cultural adaptations too, if having the TV on, if there's a teen, for example, in the room and they don't want anybody else to hear them, that may be the way to drown out the noise. So we've got to think about those things too. And again, they're in their own environments. And so we need to consider that when we're talking to them. One of the things that happens sometimes is blur with boundaries, because we're online and they have access to the email or the telephone number that you're using to speak with them and engage in services, that if something happens, they want to reach out right then and not wait for their next session. So the bullet before that talks about rapport building and that consent and intake process. I definitely go over that with them as far as what expectations are, and should there be a crisis or emergency, there are procedures for that. And I also not only tell them at the intake assessment, giving consent time, but I also have that as an auto message that goes out. If this is an emergency, contact 911, go to your local emergency room. And it's also on the voicemail, just to give an additional reminder of how to handle crisis and emergencies. Dr. Evans, what do you have in place for crisis emergencies and ensuring that boundaries are adhered to with the increased access that comes with technology?
Mm-hmm. I think one of the most important things is to confirm actually where they're going to be. And so, often when I'm talking to individuals, it's confirming their address, because I want to make sure if they do say something that makes me feel they're unsafe, that I have an address where I can call law enforcement to go and check on them, or, so I think, yeah, and that's been my number one. And usually I can confirm that visually, or, hey, are you at home today? If I feel that they are in a position where we need to assess that, it's just confirming, yeah, I'm at home today. Yeah, I'm at my mom's today. Oh, does she live in the area? And sometimes it's just being more aware of that, whereas normally if they came into my office, I might not be as aware of confirming where are you staying and what are you doing, just for my own knowledge, to make sure if anything happens, I can ensure their safety.
And Dr. Evans, if we could go to the next slide, please. I want to, again, remind our audience that you can feel free to pop in questions and answers in the chat. But Dr. Evans, I'd ask as I transition out of the presentation that maybe you talk to our participants about telebehavioral health in differences in the high context versus low context cultures, because there's a lot to be learned about that. Mm-hmm. And I will turn it over to Dr. Evans. Thank you, everyone, for participating.
Mm-hmm. Right. So as we think about cultural adaptations, this was an area that I find essential. Cultural adaptation, when we look at actual telebehavioral health, it's taking what we are doing and being mindful of the cultural impact of, often mental illness. When we look at communication practices, we use culture in every single communication that we have. I like to say that sometimes cross-cultural communication is like skin. You don't know it until you rub up against someone else's. And so often as we're communicating and as we're participating in that conversational feedback loop, telehealth, all of a sudden it changes it. Throughout today's presentation, I talked a lot about context. Throughout the different areas that we were talking about, I was working to highlight, the context and the environment. And when I'm talking about context, I'm talking about not just the location that I'm sitting with, but also our relationship. Who am I as the professional? Who are you? And this also integrates our race. It integrates our age, our gender. It incorporates all of these things that make us who we are. And so I'll take a circumstance, in a normal, in-person therapy session where someone comes in, and they sit down across from me. And I always joke, it's like, okay, I've never had a client who took my chair. Why? Because they read the room, it's okay, that's the big chair over there by the desk. Even though it's a very nice chair, they sit at the couch or the multiple other chairs that are in the room. And it's because they come in and they read the contextual clues and they're like, okay, that chair is most likely, where the doctor sits. And so these things happen all the time. And so when we think back to our communication principles, we're looking at those ideas of how we understand the room, and it's different based on culture. And so when we're thinking about, high context versus low context culture is a cultural adaptation principle that I found very helpful as I'm thinking about my clients and how they're understanding our interaction. A high context culture is one that pays a lot of attention to what's going on, let's say the nonverbals. And when they are understanding what's being said, they're doing it based on all of the environmental cues and the nonverbals that are happening. A low context culture pays very much attention to the words. One might even say semantics. So I mentioned earlier, that I live in the Chicagoland area, so northern part of the United States, generally in the Midwest. And we tend here in the Chicago area, we tend to have a very low context culture. It doesn't mean the environment doesn't matter. However, in majority culture, and especially professional culture, we're really paying attention to the words that are being used, as opposed to if I go, I'll say, go into Mexico, where, again, I work a lot with the Latinx population. It is incredibly contextual. I might say the very same thing I could say, here in the Chicagoland area, but it's read differently based on my perception, based on, who I'm speaking to. In the language, we even have different words for somebody, a formal way of speaking versus a casual way of speaking. And so telebehavioral health changes all of this, because all of a sudden it in some ways neutralizes the room, because no longer do we have chairs that we're sitting in. However, those contextual clues, sometimes I can't necessarily read them. And so this is one thing I want to offer you, leave with you regarding our cultural adaptation. It's to be aware of what's going on, contextually for the client. And what I found in doing these cultural adaptations is I have to be much more aware of the situation that the person's in. Like I mentioned before, if they're sitting outside of an apartment building, it gives me a contextual indication, often of, sometimes my clients fight to find a space, and I have to explore, okay, is the space not available because it's just there's too many people in the home? Is it because your counseling isn't prioritized? What is happening here? That has brought you to choose the space that you have chosen for your therapy. And that can be very informative as to some of the things that I will be working with the client, and understanding that particular culture, especially if it's different than yours, asking the client about their own understanding can be very important. On the other hand, if you're working with a client who is very, very, I'll say semantic, cares a lot about those words, I know I often have to adjust as well, because I tend to be in a higher context than many of my peers due to my own culture. And so being in a lower context environment, especially a professional context, I'm always thinking of the story behind the word. What's the context? Where are they? What's their relationship to me? When sometimes that just doesn't exist. The word is exactly what the word, what it was supposed to be. And so it's just understanding those things, especially as we go through and use many of our theories that may or may not be useful with certain cultures. I always like to refer people to, at the end of the DSM-5, there is a wonderful interview. It is a culturally competent interview that I often adjust many of my, especially now my telebehavioral health intakes and assessments, because that particular assessment opens up questions in a way that helps the clinician understand context a little bit better. Because I know many of our questions and our assessments forms were built on the presumption that they would be done in person, which does change. Think about your assessments, and it's describe how the individual looks, or describe, are they oriented to person, place, time. Many of those things, we get just from our, what I like to call our spidey senses of looking at people, when often now using telebehavioral health, we have to be much more accurate or active in talking to people about these particular things and confirming that. So just as we think about cultural adaptation, that's one of those things that I think is the crux, of what we're looking at. So today, during our talk, we've talked a lot about, thinking about culture, but also some of the nuts and bolts of being able to use telehealth, and telebehavioral services. I know there are so many different situations. Like I mentioned, I both work, for a hospital, but also in an outpatient environment, and often the availability of resources is so different. And when we're thinking about both culture and telebehavioral health, both are things that, well, if I talk to anyone, I'm brand new to their particular culture, and so there's always training and learning and questions that have to be asked, which right now is the same for many of our services that are being offered in telebehavioral health as the world changes so much. I know even I've enjoyed our conference where we have this Remo thing, brand new. I've been showing it to some of the people I know of, just going, wow, this is a whole different way of conferencing even. I got stuck at a table earlier, my friends in the background can laugh at that, because it's just new, and I know that right now we are only at the beginning of this, and we're going to continue to develop, especially in mental health, where we found that this is so beneficial. So some of the resources that I wanted to share, we developed a one-pager that's available on your Mobi event. You can click, and I believe there's a one-pager there, and it has multiple training resources that are available to you, that both offer training and offer best practices as we continue to go forward in offering telebehavioral health. One of the most valuable things that I've seen in a while. One of the things I added in there, because this is also about cultural adaptation, and that the cultural piece, culture is what allows us to connect with people. When your client says that, yeah, I really feel connected to my therapist, it's because you're understanding and reflecting and providing feedback within that cultural environment. And so that continues to happen even in a telebehavioral health setting. And so therefore, I wanted to highlight some of the services that are on that one pager, in addition to many services on telebehavioral health, which are great, many trainings. I also have to highlight there are some resources from the Mental Health Technology Transfer Centers, which does a ton of work in cultural adaptation and have a lot of trainings completely free that you can attend, that have expert speakers from across the country that I've really loved. And if you haven't seen the technology transfer centers, they are around the country. There's different ones that center all across the country, and then specific ones that focus on the Latinx population, also individuals in the Caribbean and Native Americans and Pacific Islanders. And so therefore it looks at a lot of these specialized areas and has webinars on that and how those specialized populations are interacting with telebehavioral health, which, especially if that's your population, is a really, really great find. So I highly recommend that. And so as I tie this up here, are there any additional questions that you might have at this time? I don't think I see any in the Q&A. All right. If there are none, of course, please, you can connect with me in the event. You can certainly connect there. Here's Michelle. I'll let her finish us up.
Hey, y'all. Thank you so much for joining us today. It's great to have you here for this awesome, crucial information shared today. Just a reminder about the one pager. Make sure you grab that. Make sure you share that with anyone that you think would benefit from it. And then I also just want to share, we have a request of you before you leave us today. I'm going to put a link in the public chat for us. This is a survey. This is actually to help get data regarding the quality of this event. So we just request that you just take a moment, take a brief survey to give us some feedback about that. And then I really want to thank our speakers, Dr. Carey and Dr. Michelle Evans, for this crucial, important conversation today. We really thank you for joining us. And we also hope that you enjoy the rest of the summit. And I'll just take we have actually one more question in the Q&A. So this is great. If I were describing this session to a coworker, what might you say are the 1, 2, or 3 major takeaways? What a perfect way to end.
Mm-hmm. Oh, I love it. And I thank you for the prompt. So the first thing, my number one, of course, would be the understanding that telebehavioral health, when we understand your own culture and how your own culture and privilege impacts your, how you offer telebehavioral health. Number 2, consider culture and cultural adaptation in understanding and being able to offer the best telebehavioral health. And number 3, make sure you know the basics, to consider all those elements that I know we had the bullet points of, your normal processes that you go through for telebehavioral health when you are approaching telebehavioral health and on an ongoing basis. So thank you very much for the question.
Amazing. Wonderful. Well, if there are no further questions, then we will send you away with our gratitude. Please enjoy the rest of the summit, and we'll see you here next year.